Hello, everybody. Today we are going to discuss the evidences on the stroke. So we have this 61-year-old male patient who was a known case of diabetes mellitus and hypertension. He presented to us with the chief complaint of right-sided weakness started from the morning 6 a.m. Then he presented to ER at 8 a.m. and CT was taken, showed no evidence of the bleed. So decision of thrombolysis was taken. Now the question is, which thrombolytic agent should we use and what is the window period for thrombolysis? So initially this NAINS trial, which was published in December 14, 1995, uh, and the conclusion of this trial was if we administered intravenous tissue plasminogen activator within 3 hours of onset of stroke, then it has improved clinical outcome at 3 months and it was associated with increased intracranial hemorrhage. Now the next on the window period in September 25, 2008 in NEJM, a CAST trial was published which they have extended this window period to 3 to 4.5 hours and they have conducted thrombolysis with the alteplase and the inclusion criteria for this extended for this window period was different that we have already seen in our stroke series. And the conclusion of this trial was intravenous alteplase administered within 3 to 4.5 hours after onset of stroke significantly improved clinical outcome in patient with acute ischemic stroke. But the alteplase was associated with increased incidence of intracranial bleed. So there are two agents which can be used for the thrombolysis of the stroke, tenecteplase and the alteplase. But the difference between these two agents is alteplase has FDA approval and tenecteplase is not FDA approved. Now the next trial which was published in 2018, that was Wake Up trial. In this, they have extended window period further they have extended window period and they have studied mainly those patients who have presented to us with unknown time of onset. So what they have did is this uh, that patient who had ischemic stroke, which was visible on MRI diffusion flare imaging, but not on this flare. They have thrombolized the patient, considering this stroke must have occurred within 4.5 hours. That means if it is visible on the diffusion weighted imaging, but not on the flare, that means still it is salvageable. So, and the conclusion of this trial was the acute stroke with the unknown onset of the time, intravenous alteplase, guided by the mismatch between diffusion weighted imaging and the flare in the region of ischemia, resulted in the significant better functional outcome and numerically more intracranial hemorrhage than the placebo at 90 days. So further in 2018-19, the extent trial has published, which has increased this window period to the 9 hours. So what they have did is they have randomly assigned the patient to receive intravenous alteplase or placebo between 4.5 to 9 hours after onset of stroke or awakening within the stroke. Uh, and this Huh. And they have involved the patient with ischemic stroke who had hypoperfuse but salvageable region of the brain detected on the automated perfusion imaging. The conclusion of this trial was among the patients in this trial who had ischemic stroke and the salvageable brain tissue, the use of alteplase between 4.5 to 9 hours after the stroke onset and at the time of the patient awake with the stroke symptom resulted in higher percentage of the patient with no or minor neurological deficit than the use of placebo. There were more cases of the symptomatic cerebral hemorrhage in the alteplase group than in the placebo. Then recently, this timeless trial was published in the NAGM. In that, they have, and the title of this trial was Tenecteplase for the stroke at 4.5 to 24 hour with perfusion imaging selection. And what they did is this was a placebo control trial which involved a patient with ischemic stroke to compare tenecteplase with placebo administered between the 4.5 to 24 hour after the time that patient was last known well to be normal. And the patient had to have the evidence of occlusion of middle cerebral artery or internal carotid artery and salvageable tissue as determined on the perfusion image. And then they have studied the outcome of the patient. And the conclusion of this trial was tenecteplase therapy was initiated 4.5 to 24 hours after stroke onset in patient with occlusion of middle cerebral artery or internal carotid artery, and most of them have undergone endovascular thrombectomy, and it did not result into the better clinical outcome than those with the placebo. But the incidence of the symptomatic intracranial hemorrhage was similar in these two. Now, the next was the extent taken tenecteplase trial, which was published in 2018, again in NEJM. And in this trial, they have compared the result of tenecteplase versus alteplase before thrombectomy for ischemic stroke. And the result of this trial was tenecteplase before thrombectomy was associated with a higher incidence of reperfusion and better functional outcome than alteplase among patients with ischemic stroke treated within 4.5 hours after symptoms. So they have added recommendation in 2019 stroke guideline that if you are planning for mechanical thrombectomy, and before that, if you want to thrombolize the patient, then go for tenecteplase instead of alteplase. Now we'll see the this with endovascular thrombectomy. What are the inclusion criteria? So the inclusion criteria for the endovascular thrombectomy are pre-stroke modified Rankine scale score 0 to 1, acute ischemic stroke receiving IV this recombinant tissue plasminogen activator within 4.5 hours of the onset, occlusion of IC and proximal MCA, age more than or equal to 18 years, then NIHH score more than or equal to 6, aspect score more than or equal to 6, and the treatment initiated within the 6 hours. And the exclusion criteria, any contraindication of the contrast agent or endovascular therapy, contraindication of the intravascular therapy, and presence of severe renal disease. Now they have published, now the ESCAPE trial was published in NAJM, which assessed the randomized assessment of the rapid endovascular treatment of ischemic stroke. And the conclusion of this trial was among the patient with acute ischemic stroke with proximal vessel occlusion, small infarct core, and moderate to good collateral circulation, rapid endovascular treatment, they have improved functional outcome and reduced mortality. Now, again in 2015, the SWIFT frame trial was published, which was stent retrieval thrombectomy after intravenous tissue plasminogen activator versus tissue plasminogen activator alone in stroke. And what they exactly did was they randomly assigned the eligible patient with the stroke who were receiving or had received the intravenous TPA to continue with the TPA alone. That was so this patient they have included in the control group, or to undergo endovascular thrombectomy with the use of stent retriever within the 6 hours after symptom onset, and the patient had confirmed occlusion in the proximal anterior intracranial circulation and absence of large ischemic core lesions, and then they have studied the outcome. And the conclusion of this trial was in patient receiving intravenous TPA for acute ischemic stroke due to occlusion in proximal anterior intracranial circulation, thrombectomy with the stent retriever within the 6 hours after onset improved functional outcome at 90 days. Then in 2015, Mr. Clean trial was published, which was again randomized trial of intraarterial treatment for acute ischemic stroke. And in this patient, they have randomly assigned eligible patient to either intraarterial treatment plus usual care or usual care alone. Eligible patient had proximal arterial occlusion in anterior cerebral circulation that was confirmed on vessel imaging and that could be treated intraarterially within the 6 hours after symptom onset. And they have studied the outcome here. And the conclusion of this trial was in patient with acute ischemic stroke caused by proximal intracranial occlusion of anterior circulation, intraarterial treatment, if we administered within the 6 hours or 6 hours after stroke onset, was effective and safe. So till this 2015-16, so we were knowing that this window period of this endovascular treatment was 6 hours. Then in 2019, down trial was published, which have extended this window period for thrombectomy patient. What is this trial? This trial was thrombectomy in a thrombectomy 6 to 24 hours after stroke with mismatch between deficit and infarct. So what is the methodology of this trial? So they have included the patient with occlusion of intracranial internal carotid artery or proximal middle cerebral artery who had seen been normal to be well 6 to 24 hours earlier, or who had mismatch between the severity of clinical deficit and infarct volume, and mismatch criteria defined according to age. So the patient were randomly assigned to thrombectomy plus standard care or standard care alone, and they have studied the outcome in this patient. The conclusion of this trial was among the patient with acute stroke who had last been known to be well 6 to 24 hours earlier, or who had mismatch between clinical deficit and infarct, outcome for disability at 90 days were better with thrombectomy plus standard care than with standard care alone. Now, the next was diffuse trial, which showed that thrombectomy for stroke can be done between 6 to 16 hours with selection by perfusion imaging. So it is a multi-standard randomized open-label trial with blinded outcome assessment of thrombectomy in patients 6 to 16 hours after they were last known to be normal and who had remaining ischemic brain tissue that was not yet infarcted. So the patient with proximal middle cerebral artery or internal carotid occlusion and infarct, the initial infarct size of less than 70 ml, and the ratio of volume of ischemic tissue on perfusion imaging to the infarct volume of 1.8 or more were randomly assigned to endovascular therapy plus standard care or standard medical therapy alone. And then they have studied the outcome. So endovascular thrombectomy for ischemic stroke, with a stroke that is 6 to 16 hours after the patient was last known to be well, plus standard medical therapy, resulted in better functional outcome than standard medical therapy alone. Uh, Among the patient with proximal middle cerebral artery or internal carotid artery occlusion and a region of tissue that was ischemic but not yet infarcted. Then in 2023, this rescue BT2 trial was published, and they have studied this tirofiban for stroke with large and medium size vessel occlusion. And the conclusion of this trial was which was involving heterogeneous group of the patient with the stroke of recent onset or progression of the stroke symptom and non-occluded large and medium size cerebral vessels. The intravenous tirofiban was associated with excellent outcome than the low dose aspirin. So we'll quickly see the methodology of this trial. It was a multi-center trial in China, which enrolled the patient with ischemic stroke without occlusion of large and medium-sized vessel, and with the NIHSS score of 5 or more, or at least one moderately severe weak link. So eligible patient had any of the 4 clinical presentation, that is ineligible for thrombolysis or thrombectomy, or within 24 hours after the patient was last known to be well, progression of the stroke symptom 24 to 96 hours after onset, and early neurological deterioration after thrombolysis, or thrombolysis with no improvement at 4 to 24 hours. So patient was assigned to receive the intravenous tirofiban or oral aspirin for 2 days, and all patients then received oral aspirin until 90 days. And then outcome was studied, and they said, and the conclusion was tirofiban has the excellent outcome than the low dose aspirin. Thank you, guys.